The following are special considerations you should be aware of during and after insertion of Mirena. Note: only trained healthcare providers should insert Mirena. Healthcare providers are expected to subscribe to accepted standards of care consistent with their specific clinic or hospital protocols. The first area of consideration is pain management. Various pain management approaches have been used. In some clinics, women scheduled for Mirena placement are advised to take non-steroidal anti-inflammatory drugs, NSAIDs, a few hours before insertion. During the procedure, the following approaches have been used alone or in combination. Local injection of the cervix with 1 cc xylocaine prior to grasping with a tenaculum. Local installation of xylocaine into the uterine cavity. Use of paracervical block. Different patients have different levels of tolerance for pain. Assess and understand your patient's level of pain tolerance. Anxious patients may need more counseling. When considering use of analgesics, be sure to provide the appropriate dose and correct timing of intake or use. Another special consideration is cervical stenosis and difficult insertions. Although uncommon, cervical stenosis may be encountered, resulting in difficult insertion. Consider the use of Hagar's cervical dilators and appropriate local anesthetics, as dilation of the cervix may cause severe pain and/or vasovagal reaction. It is the discretion of the healthcare provider whether or not to proceed if the cervix is too tight and cervical dilatation fails. Do not use force, as it may result in perforation. The risk of perforation may be increased in lactating women, in women with fixed retroverted uteri, and during the postpartum period. To decrease the risk of perforation postpartum, Mirena insertion should be delayed until 6 weeks after delivery or until uterine involution is complete. If involution is substantially delayed, for example following complicated vaginal or cesarean section deliveries, consider waiting until 12 weeks postpartum. Another special consideration is vasovagal reaction. Anticipate and prepare for the unlikely event of a vasovagal reaction by ensuring that appropriate medications, for example, atropine and smelling salts, are readily available should the event occur. In regard to contamination of Mirena, do not use a Mirena that has become contaminated or unsterile during the process of insertion. A removed system must not be reinserted. To anticipate and prepare for this unlikely possibility, have a second unit of Mirena readily available whenever you place Mirena. Fundal positioning of Mirena is particularly important in order to ensure uniform exposure of the endometrium to the progestogen, prevent expulsion, and maximize efficacy. If you suspect that Mirena is not in the correct position, check placement, for example with an ultrasound. If not available in the clinic, you may refer the patient to an appropriate facility for further evaluation. Contraceptive effectiveness may be reduced if Mirena is not completely within the uterus, is displaced, embedded, or has perforated either partially or completely through the uterine wall. In these instances, consider use of an additional form of contraception, and Mirena will have to be removed. For information on how to visualize the position of Mirena in an ultrasound, please refer to the next section. Another consideration is cervical bleeding. Following removal of the tenaculum after completion of the insertion procedure, observe for bleeding coming from the cervix before removing the speculum. In the unlikely event of excessive bleeding, the use of Monsel's solution or similar local cauterizing agents may prove useful to stop bleeding. Control bleeding as appropriate.